Very good morning to all. Today we'll be discussing on classification of antibiotics, the common broad spectrum antibiotics, and what is the special reference to usage in the liver diseases. So moving straight on to the classification of antibiotics, we know the age-old classification as natural and synthetic based upon the source of the antibiotic. Most of the antibiotics, they are derived from the fungi. Even the first antibiotic penicillin was derived from fungus, and also other bacteria like bacillus species, many of the antibiotics are derived from those like polymyxins and also from actinomycete species. Then there are certain synthetic antibiotics nowadays like astronam or avibactam, which are synthetic in nature, and the second classification is based upon the antimicrobial activity. That is, they could be either bactericidal or they could be bacteriostatic. So we know the various antibiotics at various concentrations, they can be cidal or static. Then antibacterial spectrum, it could be a narrow spectrum or it could be a broad spectrum. So this is a very vague term actually, because narrow spectrum will include those either gram positive covering only gram negative, or some of the gram positives and gram negatives, maybe some of the aerobic and some of the anaerobic. So that is there is a vague line between the two, whether the antibiotic is a broad spectrum antibiotic or narrow spectrum. Then depending upon the absorbability from the site of action, whether it is a locally acting agent or it is a systemic agent. So we know neomycin, again a locally acting agent, or we have mupirocin, which is a locally acting agent, and then we have systemic antibiotics, which usually are distributed throughout the body. Then depending upon the mechanism of action, so this is the most accepted classification, that is depending upon the where the action of this antibiotic occurs, whether it is a cell wall synthesis inhibitor like penicillins, cephalosporins, or whether it affects the permeability of the cell membrane as in case of polymyxins. Or it could be a protein synthesis inhibitor as in case of aminoglycosides or tetracyclines, or it could be a nucleic acid synthesis inhibitor like in case of fluoroquinolones. So these are the various classifications based on which the antibiotics are classified. So this is a beautiful diagram which shows the division of the gram positive bacteria. We have the gram negative bacteria, aerobes and anaerobes. So here we can get an idea what is the coverage of the antibiotics. So if we see vancomycin, linezolid, they have a narrow spectrum limited only to the gram positive bacteria. Then we have certain antibiotics like the fluoroquinolones, carbapenems and piperacillin-tazobactam, which almost cover all this spectra. So these are the broad spectrum antibiotics. The cephalosporins also, they are termed broad spectrum, but depends upon which generation of cephalosporin we are using. So as we move on from first generation to the fourth generation, this usually becomes more towards gram negative bacteria, covering both. The fifth generation are also covering gram positive bacteria. Then we have clindamycin, also has a coverage of almost all types of pathogens. We have metronidazole, mostly the anaerobic group. And so these are the various type of antibiotics that we'll be discussing. So I'll be discussing mostly on those antibiotics which we are using in our settings. Okay, so most commonly is the piperacillin-tazobactam. Indications mostly intra-abdominal infections, be it peritonitis or appendicitis, and even covering some of the anaerobic bacteroides species as well. Pelvic infections, again, it is very important, and nosocomial pneumonia, both with gram positive as well as gram negative pathogens. Pneumonia of moderate severity is usually treated with piperacillin-tazobactam, and then community-acquired pneumonia, moderate severity only, by beta-lactamase producing species of H. influenzae and other pathogens that mentioned earlier. Then also important for skin and soft tissue infections. Well, in case of hepatic impairment, dose adjustment is not required for piperacillin-tazobactam, as it is mostly a renal metabolism that it follows, and therefore not warranted in the patients with hepatic fibrosis. The dose adjustment is not warranted. Second important drug is amoxycillin clavulanate. Again, it is a BL-BLI combination, that is beta-lactam and beta-lactamase inhibitor combination. However, this is both are naturally occurring agents. They are not synthetic. Mostly implicated in the lower respiratory tract infections with beta-lactamase producing strains of H. influenzae and Moraxella, or also in COPDs, pyelonephritis, covering large spectrum of gram negatives including E. coli, Klebsiella, Enterobacter species. Then bacterial sinusitis as well with H. influenzae or Moraxella. Skin and soft tissue infections, definitely we treat with amoxicillin, clavulanate, and especially diabetic foot, also mild to moderate localized cellulitis is treated with this drug. However, it does cause hepatic impairment, liver injury occurs, and dosage is with caution in this case, and we have to monitor the hepatic function regularly if we are using amoxicillin clavulanate for a longer duration of time. Then coming on to carbapenems, again these are the most widely used antibiotics currently, because they have a very wide spectrum of activity. That is, they will cover both aerobic as well as anaerobic pathogens, gram positives as well as gram negative pathogens. They will cover the staph aureus, strep pyogenes, other streptococci like Streptococcus agalacti, viridans group of streptococci, Enterococcus faecalis, Pseudomonas, E. coli, Proteus, also Bacteroides and Peptostreptococcus species. So most of the pathogens which we are dealing are usually dealt with carbapenems. However, these are the most abused drugs also. Mostly we use imipenem or we use meropenem. Rarely ertapenem is used and doripenem is used. Well, doripenem is useful because it has a wider spectrum in terms of Pseudomonas aeruginosa. It has a better coverage as compared to the other carbapenems. So when we talk of carbapenems, why are they most frequently used or abused drugs? Because again, they have a safety profile, they have a longer duration of action, and also they can be implicated in various types of infections like skin soft tissue infections, joints, respiratory tract, intra-abdominal, urinary tract infections, urogenital infections, as well as meningitis across the blood-brain barrier, endocarditis, and also sepsis. However, they do cause a mild degree of liver impairment, but this liver injury due to carbapenems is very mild, asymptomatic, and it is self-limited. Once we stop the drug, the liver derangement will be returning to normal. So rarely any clinically apparent cholestasis may occur with carbapenems, and therefore they are good drugs in case of liver impairment. However, renal issues may occur, and also the neurotoxicity is an important issue, and drug interactions is an important issue with carbapenems. Cephalosporins, again, these are the broad spectrum antibiotics, and they, as we all know, they are cell wall synthesis inhibitors, and mainly they act on the rapidly growing organism. So if we have an active infection, they are going to work better. And in general, they are not associated, most of the cephalosporins are not associated with hepatotoxicity, bearing the exception of ceftriaxone, because ceftriaxone, which is most commonly used cephalosporin or third generation cephalosporin, which we usually give parenterally, and it usually precipitates in the bile and it crystallizes there, and therefore it leads to a biliary sludge, which lead to cholecystitis and even cholecystic jaundice. So it's very important to monitor such patients who are on a prolonged ceftriaxone therapy, because sometimes it becomes mandatory, other drugs are not sensitive, this drug is sensitive, or in combinations if you are giving, definitely we should monitor the cholestatic pattern in such patients. And it has been reported in around 3 to 46% of the patients, they may develop cholecystic or some biliary sludge, and therefore it's very important to avoid complications in these patients, that we should monitor them. Incidence may be still higher in children. That is also very important, because again, in case of typhoid fever, if it is complicated typhoid fever, definitely ceftriaxone is preferred drug, and in that case, especially in children, it is associated with more of the biliary complications. Especially the children are dehydrated, it is going to cause more of a problem. So these beta-lactams, mostly the beta-lactams that we have covered now, the penicillins, carbapenems, and the cephalosporins, they are excreted in urine. Few like nafcillin, which is not very commonly used, is excreted in bile, only 10% in urine, and therefore in case of, if we need to give nafcillin, we need to have a dose adjustment in case of nafcillin. Ceftriaxone, as I've already mentioned, we need to do a dose adjustment, and also concomitant monitoring of these patients should be done. Then coming on to the next broad spectrum antibiotics are the aminoglycosides. Now these are the natural products, some are semi-synthetic derivatives, and mostly all the members of aminoglycosides are broad spectrum except streptomycin, which has a narrow spectrum, and also it is an anti-tubercular drug. So mostly these are used in combination. We know these are bacteriostatic agents. They are used in combinations with cephalosporins or penicillins for treatment of infections with Pseudomonas or Enterobacter, Klebsiella, Serratia. So mostly the gram-negative pathogens. And amongst this, amikacin is the most commonly used. As we all know, amikacin, even in our setup, amikacin is most commonly used. We can be given in septicemia, bacterial endocarditis, peritonitis, even meningitis crosses the blood-brain barrier, pelvic inflammatory diseases, pneumonia, and also a part of anti-tubercular therapy. However, liver toxicity with aminoglycosides is not an issue, but other toxicities like we know ototoxicity, nephrotoxicity, and neurotoxicity are very important factors which determine the less uses of aminoglycosides. So though hepatosafe, the other factors may debar their use in frequent practice. Coming on to fluoroquinolones, DNA gyrase inhibitors, both gram-positive and gram-negative coverage, and they have some extended spectrum as well. That is the gram-positive coverage including penicillinase positive and penicillinase negative, Staphylococcus, Streptococci. Then we have the other virulence group of Streptococci, Enterococcus, Listeria, and Nocardia as well. So they have a good spectrum of activity against gram-positives, and also gram-negatives including Neisseria, gonorrhea, and also meningitis. Then Haemophilus, Enterobacteriaceae, almost all members are susceptible, Pseudomonas aeruginosa, and also Vibrio species. So it has a broader spectrum of activity, and therefore it is used in various type of infections like bronchitis, pneumonia, sinusitis, or UTI, or intra-abdominal infections, and various other skin soft tissue infections. So it has a broader spectrum of activity. There are mild elevations in the liver enzymes, around 1 to 3% of the patients who receive ciprofloxacin, Norflox, or Oflox. So therefore, though these elevations are transient, in few reports have been reported of acute liver injury because with these agents. So though not a reason to worry, but we should still have a vigilant eye when using these agents. Cipro and levofloxacin, mainly the elimination is renal. Hepatic failure has little impact on their pharmacokinetics, therefore relatively safe. Moxiflox, however, has a hepatic metabolism and also a biliary excretion, but this again not systematically used, not a commonly used drug, and we can easily avoid it in patients with liver diseases. Then coming on to macrolides. Macrolides, again, these are bacteriostatic agents, mainly for Streptococci, Staphylococci, even Clostridia and Corynebacteria, Listeria, Haemophilus, and Neisseria species. Clarithromycin and azithromycin are more active as compared to erythromycin against several gram-negatives, and also against atypical pathogens like Mycoplasma, Helicobacter pylori, Toxoplasma, Cryptosporidia, and even atypical Mycobacteria. So they have a broader spectrum of activity. Cholestatic jaundice does occur with the prolonged use of these agents, usually within 1 to 3 weeks of starting the therapy. There could be asymptomatic elevation in the liver enzymes, which could be again a mimicking factor because the patients already have deranged liver function, and if you are giving macrolides in such patients, there may be some alteration in the liver enzymes as well. So reported in 1 to 5% of the patients treated with macrolides. Acute hepatocellular injury may occur and usually arises within days following the starting of the therapy. So it may cause a drug-induced liver injury, and often if it is associated with re-exposure. So if the patient is already treated with a macrolide and after a few days again treated with a macrolide, chances of liver injury are very high. Tetracyclines, again bacteriostatic agents, both gram-negative, gram-positives also work on spirochetes, chlamydia, leptospira, mycoplasma, rickettsia. So a typical pathogen coverage is higher with tetracyclines, and amongst the tetracycline, minocycline is most commonly implicated in causing liver injury. So most of the times what happens is we have only minocycline sensitivity as a bounding factor, like in case of Acinetobacter baumannii infections, or we have recently the Chrysobacterium infection. So in which case the minocycline is the only sensitive drug, and so in that case we should have a monitoring of the liver enzymes, whether with the starting of the drug the liver enzyme derangement is there, because it is one of the top 10 antibiotics which lead to drug-induced liver injury in most of the developed nations, the data says. Other antibiotics not commonly used, like clindamycin, it has extensive hepatic metabolism and concentration and prolonged half-life in cirrhosis. Dose adjustment is required in severe liver disease. Also metronidazole, it has a broader spectrum of activity, mainly metabolized through the hepatic cytochrome P450, prolonged half-life in liver derangement, and due to concentration dependent activity, usually increasing the dosage intervals is usually preferred if there is severe liver disease. Otherwise, because if you are going to reduce the concentration, that will not cause any effect of the drug on the pathogens. So why is it important to know the liver function and also the antibiotic activity? Because definitely we have these bad bugs and we have no drugs for them, especially the escape pathogens, that is the Enterococcus, we have the Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, and we have Pseudomonas aeruginosa, Enterobacter species. I think so these are the most commonly encountered pathogens everywhere now in the ICUs, and they usually escape the action of most of the antibacterial agents as well. So if we see the various types of infections in the ICU, be it a ventilator-associated pneumonia or a UTI or a bloodstream infection or a surgical site infection, these are the common 5 pathogens which we encounter most commonly. In the gram-positives, obviously it is Enterococcus or Staphylococcus, but in our settings, both these pathogens are at a low frequency, and therefore gram-positive coverage, usually if the cultures are negative, we can avoid a gram-positive coverage for a longer period of time. And again, most importantly now what we are facing is the MDR, the PDR, the XDR, right? The extended drug resistance, the pan drug resistance is more important to deal with. This report from the State of World's Antibiotic, it has shown that India leads in the antibiotic resistance, be it the carbapenem resistance in E. coli or the carbapenem resistance in Klebsiella pneumoniae, or in case of Acinetobacter, which is very high, 77%, and also in case of Pseudomonas aeruginosa. So definitely also other not only carbapenemases, metallobeta-lactamases, also we are topping the list with around 75% of the isolates in various studies reporting the presence of the metallobendium, that is the metallobeta-lactamase in such isolates. So what is the way forward to it? So this resistance problem is continuously increasing. This is the data from ICMR, where we have mostly the gram negatives, and again all are resistant to imipenem, meropenem, the carbapenem resistance, and even the polymyxin resistance is on the rise. So we have few options which are broad spectrum, which can be included in our treatment modalities, that is Fosfomycin. Again, this is a unique drug, various with a varied mechanism of action and a broader spectrum of activity. Okay, it has both gram positive as well as a gram negative coverage. As you can see, gram positive Staph aureus, Streptococcus pyogenes, Streptococcus pneumoniae, Enterococcus faecalis, and even the coagulase negative Streptococci. In case of gram negatives, most common pathogens like E. coli, Pseudomonas, and Klebsiella are treated with Fosfomycin. Also others like Proteus, Enterobacter, because in case of Proteus, again because it is resistant to colistin, many of times we don't have any option, so Fosfomycin is an option for Proteus infections, Enterobacter, Citrobacter, Serratia, Neisseria, and Shigella and Salmonella as well. So it has a broader spectrum of activity. Acinetobacter, Stenotrophomonas, Burkholderia species, especially Cepacia, Staph capitis and Staph staphylococus and Mycobacterium tuberculosis, they are intrinsically resistant to Fosfomycin. So we should not use Fosfomycin for Acinetobacter or Stenotrophomonas, which are commonly seen in our settings. Well, it has a synergistic effect. Definitely monotherapy with Fosfomycin is not advocated, barring for UTI with E. coli or Enterococcus faecalis. Mostly given with other agents, and it has a synergistic effect with Aminoglycosides, colistin, carbapenems, Fluoroquinolones, and Tetracyclines as well. So if the organism is a Klebsiella pneumoniae carbapenemase producing, we can combine it with carbapenems, we can combine with Aminoglycosides, colistin, and Tetracycline. Against NDM producing Klebsiella pneumoniae, definitely we can, it has a known synergy with colistin. ESBL producing Klebsiella pneumoniae and E. coli, Fosfomycin with carbapenems exhibited a better in vitro synergistic effect, and no antagonism was seen in the above combinations. So where do the drug stands in case of the treating in the place of therapy? So if there are MDR infections due to Enterobacteriaceae, which are most commonly we face, so, and also XDR, the extended drug resistant Klebsiella pneumoniae species also can be treated with Fosfomycin. ESBL infections as carbapenem spreading agent is also important action. However, in case of pediatric patients, because there are very less studies, the dosage recommendations, they have a very limited data. However, the drug can be used in pediatric population. So, and also the hepatic impairment is not there with Fosfomycin. So, in case of liver disease patients, Fosfomycin can be given. Another broad spectrum agent newly added is the Caftazidime avibactam. As we can see, it has a broader spectrum of activity with complicated UTIs, mostly the gram negative pathogens, complicated intra-abdominal infections, hospital-acquired pathogens as well. And however, the organisms which are not susceptible to Caftazidime, avibactam are Staph aureus, both methicillin sensitive as well as methicillin resistant. So Staph will not be sensitive. Anaerobes, they have no activity. Enterococcus species, again no activity. Stenotrophomonas and Acinetobacter, again no activity. So these agents we cannot use Caftazidime, avibactam for these infections. Bacteremia associated with or suspected should be treated with the above indication. So again, bacteremia also we can give this drug. So it can be used, and I think so it is used, but again resistance has developed over a period of 2 years to these agents as well. We have Ceftriaxone-Sulbactam EDTA, I think so most controversial drug that we are using, or the most questionable drug that everyone has questions because it is not FDA approved. However, the data and in vitro susceptibilities are very good, claiming a very broad spectrum of activity and also a good action in vitro. So, what is the mechanism of action of Eloris or the Ceftriaxone-Sulbactam EDTA? Okay, so basically it has 3 molecules. It has a ceftriaxone, that is a cephalosporin. We have sulbactam, a beta-lactamase inhibitor agent. So again, the BL-BLI combination is there, but EDTA is also there. So what is the role of EDTA? It is an ion chelating agent. So zinc ion chelations in the metallo-beta-lactamases. We know the metallo-beta-lactamase activity, that is like in case of NDM, it depends upon the zinc ions. Okay, so for the efflux pumps, it will have the zinc ions in the membrane. So the transportation of the drug will be depending upon these calcium channels, zinc ions and the magnesium ions. Okay, so most important activity of EDTA will be chelation of these ions, and therefore the activity of the pumps will be deranged, and therefore the organism, it cannot produce these inhibiting enzymes, or they cannot throw back the antibiotic with the help of the efflux pumps. So effectiveness against MBLs is there theoretically. Efflux transporters, again antibiotic sensitivity is increased because the efflux transporters are affected, and membrane permeability is increased by chelating the magnesium ions. So magnesium ions are chelated, the membrane permeability will increase, and therefore there will be increased concentration of the drug inside the organism, and there will be cell death. Then there will be the Curli formation prevention, and penetration in the cell wall is better. So these all lead to the membrane porosity. So there will be increased membrane porosity. There will be no ions to hold back the integrity of the membrane, and therefore increased porosity of the membrane will be there. Increased drug will be penetrated inside the pathogen. Downregulates efflux pumps overexpression. Also, it prevents bacterial conjugation, that is the plasmid mediated transfer. So the most important thing about NDMs or the carbapenemases is the plasmid mediated transmission, right? So why do these infections usually transfer from one patient to another in the hospital? It is because of the plasmid mediated transfer from the patient surroundings or the fomites. So this conjugation is also prevented by some mechanism with EDTA. And it also downregulates the ESBL or the MBL production as it chelates various type of ions. So theoretically, it is a very sound and robust mechanism of action. Though we don't have any other option, because when we are using in XDR and PDR cases, and actually in very sick patients, we cannot actually correlate the toxicity of the drug, or it is actually the patient infection that is superpowering. So that is there are not many RCTs from India. There is one study, multicentric study from AMU and PGI Chandigarh, where they have shown that it is non-inferior to meropenem in case of UTI and in case of sepsis as well. So, but still this drug has to be studied, and till then we can just have a trial and error for in case of PDR infections. So it has a spectrum of activity against Acinetobacter, E. coli, Pseudomonas aeruginosa, Klebsiella, and activity also against and wide range of ESBL and MBL producing pathogens. So theoretically really a good drug to use, but again practical use, and also we need RCTs to have a better correlation with the toxicities and usage of these drugs. Liver function wise, it is safe to use in liver deranged patients. So this is the recent recommendation by the for use of various antibiotics in case of carbapenem resistant enterobacterials based upon the in vitro susceptibilities. So if it is a pyelonephritis or a catheter associated UTI, Caftazidime avibactam or a meropenem avibactam, which is not available here, or imipenem can be used. Infections outside the urinary tract which are resistant to ertapenem, meropenem and carbapenemase producing, again recommendation is ceftazidime avibactam with meropenem avibactam, and which again is not available but maybe soon available in India. And again OXA48 like carbapenemases, we know OXA48 is important in case of Pseudomonas infections and other MDR pathogens as well. So in that case ceftazidime avibactam is very useful. If we have to use in NDM producers as well, we have to add on a aztreonam to this agent. So ceftazidime avibactam plus aztreonam for OXA48 and NDM producers. So antibiotics which should be avoided in liver, so this is just a summary, which should be avoided in liver disease are chloramphenicol, erythromycin, tetracyclines, ATT, mostly the various combinations, but hardly we can avoid them, the griseofulvin, nalidixic acid and nitrofurantoin. And these which need to be extra cautious, as I've already mentioned, a few penicillins and cephalosporins, also macrolides, we have to administer with caution. One important problem with giving antibiotics, the broad spectrum especially, all of them are usually associated with a infectious complication like Clostridium difficile associated diarrhea. And because in liver disease there is a higher mortality, also length of stay increases, and also the patient overall charges increases with the C. diff infection incoming with the use of increased antibiotics. So definitely we should have a cautious use of antibiotics in such patients, in cirrhotics. But however, when we are treating MDR, XDR or PDR pathogens, stewardship takes a backseat, and definitely we need to have combination therapies and we need to add on increased drugs. That is completely justifiable. But in such cases, again, C. diff may be an important risk factor. So this is again a review which shows the how to prescribe medications in cirrhotic patients, and again the same list of antibiotics which are usually not avoided in cirrhosis. However, there are many contradicting papers. When I saw the papers, there were many contradicting papers which said that one should prescribe this and one should prescribe that, but it was very contradicting to each other depending upon the Eastern and the Western data. Okay, so there has been recently, just a few days back, ICMR has given a guidance on the carbapenem resistant gram-negative bacteria. So if there is presence of metallo-beta-lactamase, go for a ceftazidime avibactam and aztreonam if sensitive. Otherwise, other options like polymyxins, tigecycline and aminoglycosides can be given depending upon the site of infection. Metallo-beta-lactamase plus an OXA48 producer, if it is there, then again ceftazidime avibactam and aztreonam. With polymyxins, tigecycline and aminoglycosides as the options. OXA48 like if the picture is like OXA48, we should use ceftazidime avibactam. Options are polymyxin, tigecycline and aminoglycosides again. KPC producers, again ceftazidime avibactam is recommended, and polymyxins, tigecycline, aminoglycoside depending upon the type of infection. Then carbapenem resistant Acinetobacter, though we have lesser amount of Acinetobacter as compared to Klebsiella and Pseudomonas, but still treatment options could be higher dose Sulbactam, polymyxins, minocycline, we can give tigecycline, not for UTI or not for bloodstream infections as well, and other agents could also be tried like trimethoprim sulfamethoxazole, again liver injury a factor restricting its use. So these are the options for carbapenem resistant Acinetobacter. They have also mentioned the duration of therapy that has to be given. Ventilator associated pneumonia or hospital acquired pneumonia, it is 7 to 10 days. Complicated UTI, it is 10 days. Catheter associated UTI, it is 5 to 7 days. Again, this is very difficult in ICU patients because there is a prolonged culture positivity in such patients, which could be because of the various lines and colonization, and secondly it could be some internal source of infection that is still there, and therefore it's very difficult to restrict ourselves to this duration of action. If we see the sensitivity pattern in E. coli in our place, again previously Loris and Fosfomycin both were having a good sensitivity. The sensitivity is reducing now. Ceftazidime avibactam, again when used singly, it will have restrictions, but with aztreonam definitely the sensitivity is going to increase. Okay, so I think so it's lot of pharmacology for the morning, and I can see some sleepy faces at the back. So just 3 quiz questions for all of you, and you have to give the answer. You have to identify the parenteral cephalosporin, which is active against Streptococcus and methicillin sensitive staph, and also has some activity against Bacteroides, sensitive to ESBL, but it is resistant to AMC producing pathogens, and treatment of the rapid grower NTM as well. And it is a surrogate for methicillin sensitivity. Which is this antibiotic? Cefoxitin. I think so. This everyone can answer. Acts against MDR, Pseudomonas, Acinetobacter, but no activity against Serratia, no activity against Strep, Staph, Enterococcus, and anaerobes. No activity against Burkholderia. It also can be given with nebulization. Which is this antibiotic? The most abused drug here. Which is this antibiotic? Anyone? It is colistin. And last one, the one which acts on pneumocystis, toxoplasma, actinomyces, some viridans and Streptococcus angiosus as well. Good activity against anaerobic streptococci, but no activity against Bacteroides. Poor activity against Enterobacteriaceae, Pseudomonas, and Acinetobacter. Also has an antitoxin activity and inducible resistance with erythromycin. So this is very simple, which covers mostly anaerobes and the gram-positives and the gram-negatives as well. Clindamycin, right? So it has an inducible resistance with erythromycin as well. So I know it's very difficult to accumulate all the antibiotics together, but still this is an attempt. And definitely when Alexander Fleming discovered penicillin, same time he warned that there is going to be resistance, so use of antibiotics has to be cautious. Thank you all.